this afternoon is first the concept, then I'll talk to you about case selection, and finally the long-term follow-up. We now, remarkably enough, have 5-year follow-up data on the MitraClip. So, like so much of interventional cardiology, we pickpocketed the cardiac surgeons to develop the mitral clip. It is developed directly from a concept called the Alfieri stitch, developed by the Italian surgeon who, some years before, put sutures in the middle of the mitral valve, bringing together the anterior and posterior leaflets to create the double-barreled look that you see at the bottom left. The idea of that rather simple procedure was that it would coapt the leaflets that were previously not coapting and thereby reduce the mitral insufficiency, but in addition it would create a tissue bridge within the mitral valve annulus, limiting its dilatation, and by so doing also having a structural effect on limiting left ventricular dilatation, and because it is a clip or a suture, would support the durability of the repair that was undertaken. An interesting, if somewhat counterintuitive concept that you could treat mitral insufficiency in such a manner. This is the device which you saw earlier today in Dr. Sharafa's superb presentation on echocardiography of the mitral valve. It is a clip that has a cover on it. It is passed across the intraatrial septum. It is crucial, the placement of where you bring that device across the septum. You then pass it down through the mitral valve and then withdraw it back up against the leaflets, trying to catch both the anterior and posterior leaflets, ideally in a central regurgitant jet, but other locations are possible as well. Here is a schematic of the leaflet clip being applied. And now, could you advance to the next slide for me? I don't think I can get off the... See if I go up here, maybe. And here you see that clip in action, creating a double-barreled mitral valve where there previously was single orifice. The passage of the clip across the valve is shown in this dynamic echocardiogram. There's the clip across the valve. You can see the two leaflets, and now it's pulled up and it grasps the two leaflets and eliminates that flail look of the leaflets that existed beforehand. So this is the third and final grasp that solves the problem of mitral insufficiency. I'm trying to get the arrow off the image there. Here is a individual patient with severe mitral insufficiency. Looks good, doesn't it? That echo? I am not sure whether to go backwards on this or not. I think I'll try to going backwards. I'm clicking on backwards. Okay. Look quickly, but in any case, I think if you just focus on the left panel, you'll see that that is 4+ mitral insufficiency. This is actually the best data that I have to show you right here. And let's go on to the next. I hope that you saw that was severe mitral insufficiency. If we can, we could play it one more time. If we can't, that's okay too. So let's just look at the left panel and you'll see how severe it is. Okay, so you can see it here. It's a central, there it is. And here is 1 month follow-up, and I hope we can keep it on long enough for you to see. There is mild mitral insufficiency still present. Again, if we can, if it only stays up for a second, look at the left panel, and you can see it's still present, but it is categorized by our echocardiographer as mild. The indications and exclusions for the mitral valve clip are fairly critical. We only use it in non-rheumatic mitral regurgitation, either degenerative or functional, functional being mitral insufficiency caused by left ventricular dysfunction. There are other conditions in which it is sometimes used, so-called expanded indications like failed surgical repair of rim annuloplasty or snapping of an artificial cord, has been used in hypertrophic cardiomyopathy to limit systolic anterior motion with mitral regurgitation, and is being used occasionally in end-stage heart failure to delay the time of heart transplantation. There are anatomic exclusions, which Dr. Sharafa nicely showed you by echo and gave you the definitions of these exclusions. In essence, it is if there's not enough tissue to grab onto, if the gap between the two leaflets is so great that you can't pull them together, if it's calcified, or if the valve is too small so that if you clipped it, you would create mitral stenosis. So conceptually, it's pretty easy to understand what the exclusions are. And they are specific, as you saw in one of the previous talks. I am clicking away up here. Well, at least now you get to see the images that we didn't get to see before. Let's see if I can get it to move. Maybe if I move it. So if possible, could you move us to the next slide? I seem to be frozen in time up here. Mm-hmm. Yes. Mm-hmm. Well, while we're waiting, the data that I'm going to show you is first from Cedars-Sinai. We have the largest volume in the United States, not the largest volume in the world, and we were significant contributors to the significant contributors to the principal trial, which was called which is a so-called pivotal trial. A pivotal trial is the one at the FDA where the data is used to make or break their decision as to whether the FDA is the Federal Drug Administration of the United States, who approves devices for use. We can't use a device except under experimental conditions, but cannot be used commercially until the FDA, Federal Drug Administration, gives its approval. And the data that we will look at is from the so-called Everest trial, which was the pivotal trial that was used by the FDA to make its decision that it would be all right to use the MitraClip. We only got approval for that about a year or so ago. The data that I'll show you from Cedars is collected by essentially one man. His name is Dr. Saibal Kaur. He's a native of India, Calcutta, or Kolkata as it is now called. And Saibal is the son of a long-standing famous family of India. His father was president of the Indian Society of Cardiology. And actually I call Saibal the American Airlines professor of cardiology because it seems like he's most always on a plane flying somewhere to teach somebody how to do MitraClip. He's more often in the air, I think, than he is at Cedars-Sinai. I'm not really quite sure why we pay him a salary. But in any case, here comes the anatomic exclusions. We'll go to the next slide. And there's Saibal himself, our American Airlines professor. He has performed 244 of these cases. Among the referrals that we get, if you were to send us a patient with mitral insufficiency, your patient would have about a third chance of being sent to surgery because we feel that he would be a better candidate for surgery than for the MitraClip. About a third are rejected because they don't meet the coronary anatomy, the mitral valve anatomic criteria that Dr. Sharafa showed you earlier, and about a third get the clip. Our data in these 244 patients is a 1% mortality at 30 days. Saibal is tremendously skilled clinically. He's got very good three-dimensional sense and also very skilled with the catheter. This is a difficult procedure. In my opinion, it's probably the most difficult of the interventional cardiology procedures. An order of magnitude more difficult to me than TAVR, aortic valve replacement. His time skin to skin is on average 141 seconds. I would say that is 141 minutes, which is a little over 2 hours. Sometimes it takes as much as 4 hours. It is a difficult technical procedure. And now I have trouble, let's see. Could we switch over and I'll just say next slide, please? Is that maybe? Okay, good. So the worldwide experience as obtained now in 14,000 patients have now been treated with this clip. So there's a vast experience in its use. About 2,000 of these were patients who were in randomized clinical trials. It's now commercially available in most countries, so the number of clinical trials relative to the total volume will diminish percentage-wise. Majority of these people are, as here in the data that you saw presented earlier, are high risk for mitral valve surgery, because if they weren't, they would go to mitral valve surgery, and you'll see why in a moment. And in October of last year, the Federal Drug Administration approved it for use in high-risk mitral regurgitation in the United States. The Everest trial data involves a little over 100 patients. I've forgotten the number and I can't read it here. The vast majority essentially had 3 to 4 plus mitral regurg. The study was the MitraClip versus surgery, and we now have 5-year follow-up data just recently available, and that's what I'm going to share with you. As you see, the mean age in this pivotal trial was 67 years. The majority had degenerative mitral regurgitation as the cause, about 70% to 30%. That is changing somewhat, more functional patients now being done. And as you see, 51% were class 3 or class 4 heart failure. The survival data is quite interesting. There really is no difference at 5 years between the mitral clip compared to surgery. As you can see, 93 and 92% overlapping essentially the entire time from the time of the randomization. It was a 2-to-1 randomization. Freedom from operation, however, is different, and you'll notice immediately that there is most of the mitral clip failures, the need for surgery, comes in the first year, where there's about a 20% difference between the mitral clip and surgery. After that, the mitral clip, if you've made it through that first 9 months or so, you have a pretty flat curve for need for reoperation. So if you are successful, the device appears to be, interestingly enough, durable. In terms of the mitral regurgitation grade, there is this data, which is quite instructive. About 80% of the patients were 3 or 4 in this particular database before operation, before the procedure, and after the procedure, about 80% were class 1 or 2. At 5-year follow-up, the difference between the surgery and the mitral clip is shown in the 2 data pieces that I have circled. There is about a 15% or so are 3+ with mitral clip, but as you can see, a tiny percentage are 3+ mitral insufficiency with surgical therapy. So in terms of functional class, we see the same sort of data at 5 years. A very good outcome in 91% if we call class 1 or class 2 good. But if we combine class 2 and class 3 and compare it for the mitral clip versus the outcome versus surgery, you can see that, again, surgery has a somewhat better outcome in terms of functional class. In other words, mitral clip is very good, but surgery is a little better. So, my conclusion with regard to the mitral clip is that compared to surgery, it has a similar survival rate, a very good but somewhat less optimal clinical outcomes, and that if you make it through the first 9 months without difficulty or need for reoperation, the clip is durable at 5 years. Within the group that would be classified as substantially high risk, and this is another database with the mitral clip, if you look at hospitalizations, there's a clear impact on rehospitalizations, roughly, let's call it 0.8 hospitalizations per year prior to the mitral clip, reduced in half by the placement of the mitral clip. So it has a substantial economic impact on patients who have severe mitral insufficiency. The conclusions that I would draw with relationship to the mitral clip for severe mitral regurgitation: the clip procedure is safe. It is technically challenging, and you need to, if you are going to get into it, you need to be trained and then have a person who early on may have a learning curve, because it is one of the most difficult procedures. It induces a substantial reduction in mitral regurgitation. The example that I showed you is typical, the echo example, and that reduction in mitral regurgitation is accompanied by really substantial clinical benefit, 80% bad to 80% good in a very simplistic kind of way. Beyond 6 months, the rate of mitral valve surgery after the mitral clip is low, but you have to make it out to that time point to be parallel to surgery. The clinical benefits are durable through 5 years. Of course, there are other options. You heard about, we again picked the pocket of the surgeons who originally developed rings. I said more rings than surgeons. 3 of the rings here have the same surgeon's name. It's Patrick McCarthy. He has 3 of them. And of course, the interventionalists now have developed their own ring, which you heard from Dr. Sharafa, called the Carillon. So what we have is the interventional, oh, I must tell you about this because it just appeared in this week's Journal of the American College of Cardiology about 3 days ago. It is a fascinating demonstration of the future, and it may impact the ring particularly because it is an alternative to the ring. It is the placement of a mitral valve percutaneously, the analog of a aortic valve percutaneous placement. And what I want you to see is the schematic first. It is a sheathed mitral valve that is placed by transapical puncture and moved across the mitral valve above the mitral valve ring, and then pulled down onto the annulus itself. It's a D-shaped ring because that's the shape of the mitral annulus. When it is unsheathed, it has metal prongs that spring out and anchor it to the myocardium. You can see that in this rather poorly presented image of the X-ray image before and after release of the valve. And down below on the top panel are two patients, one a 70-year-old and one a 61-year-old. Let me take that back. That is the two on the left are a 71-year-old and a 61-year-old patient in Vancouver who had this done, and you see the echo before and after. The patient was extubated in the OR, in the catheterization laboratory, was anesthetized but then extubated, did not require any transfusion, did not have pericardial effusion following the transapical, and both are doing fine according to the authors in these two case presentations. Imagine the implication of this for the future of cardiology if this actually becomes feasible. So to summarize, you're now going to be presented by the interventional cardiologist who says, put a clip in there, and then the surgeon will come along and say, no, don't put a clip, do a surgery. And then another interventionalist will say, let's put in a valve. Well, what are you supposed to do? My suggestion is you be the big cat and you make the final decision, all of this, on which one is best for your patient. Thanks so much for your attention.